Welcome back to another edition of WIGIL, the one case that taught me the most. Today we are on ethics, and the topic is visible to you. Dr. Vibha is the speaker, and Dr. Sumana will be our moderator. It's my pleasure to introduce Dr. Sumana. She is a senior liver transplant and hepatobiliary surgeon in India. She's trained extensively and she has done a fellowship from the world famous Thomas Chazal Institute in Pittsburgh.
Sumana ma'am, I think Dr. Shruti is lost. Can you please continue?
Okay, I'll take over from here.
Yeah, ma'am, thank you.
Thank you everyone for being here today. I'm Dr. Sumana, and I would like to introduce Vibha, who's going to talk about the futility versus hope, challenges in liver transplant candidacy. If you go by the history of futility in the early medicine, it was governed by ethics and principles, and it was said that do only good or do no harm. Eventually, in the 90s, it came to the fact that people started talking, do everything that is possible. Being in transplant, many of us who are here know that it is very difficult for us on a day-to-day basis. Comparing, to have a recipient and a donor, and this question of are we doing the right thing? Is it futile? Or should we go by the hopes that we are giving to these patients? These questions keep coming again and again. And most of the times, the thought process is always retrospective. We make a decision at that particular point, but later on, when we start sort of retrospecting, then we start thinking whether it's right or wrong. Was it ethical, unethical? And there's no answer to this. And today, Dr. Vibha, who is now the head and she's heading the Department of Liver Transplant and HPB Surgery at Lilavati Hospital in Mumbai, is going to share her experiences with this and her thoughts about the topic of futility versus hope. Over to you, Vibha.
Good evening, everyone. Thank you, Sumana, and thanks, Shruti, for giving this opportunity. So I would be discussing the futility versus hope, which we always wish to give our patients, and the challenges, as Dr. Sumana mentioned, we face it day in, day out in making decisions whether a particular candidate is a suitable candidate and should we be going ahead or declining a procedure which is life-saving. So I would be discussing two scenarios, and in each I'll have two cases. And the first one is neurological status in a patient with acute liver failure. And the second scenario is pregnancy and acute liver failure. And what we did as a team, and whether we learned our lessons. And I would really have to have some discussions with our group to share their experiences and how they would have dealt with the same situation. So we, of course, learn with our each and every case which we come across. And that is what we think, but I really don't know at the end of it whether there was a real learning. It's an experience, of course. So in neurological status, when we talk about neurological status in patients with acute liver failure, we know that they can deteriorate and there can be a rapid deterioration. And that is why we offer them liver transplant on time. But once there is advanced neurological deterioration, what is the point where we say no? And there are areas where we really say no, but there are some gray areas where we don't know whether we should say no or to go ahead. Similarly, with pregnancy and acute liver failure, whether to deliver first, whether to do a transplant first, whether in a sick pregnant female we should say no, and do we have the right answer? So I would start with this famous quote that once you stop learning, you actually start dying. And I really believe that every case teaches you something, but I'm not sure whether it is true in all the situations. So our first case was a 25-year-old female, a third-year medical student who had HIV-related acute liver failure. She was fulfilling all the criteria for emergency liver transplant. And when she presented to us, she was in grade 2 to 3 encephalopathy. And we did a rapid workup for her, and the donor was her brother. We had an emergency committee. She was intubated because she was in grade 3 encephalopathy, and as it is, we had decided to go ahead. We did as a routine a MRI brain before wheeling the patient into the theater, and we found there was edema, but not too much. And we took a neurological clearance. There was no midline shift, no evidence of herniation. She was already on anti-edema measures. And we started simultaneously donor and recipient surgery. Intraoperatively, the anesthetist raised an alarm saying that suddenly there is a BIS which is almost zero, and there were unequal pupils. One side it was dilated and had a sluggish response. And we had a discussion. We called up the neurologist, and we really didn't know whether to go ahead or this was just one of the mild signs, but it was something which we informed the family at this point of time, and we went ahead. She had a smooth recovery post-op, no neurological deficit, and she was discharged on time. So if you see, when a patient with ALF has raised intracranial pressure with progression of encephalopathy, they can land up having seizures, they can have pupillary abnormalities, dilatation of pupils, sluggish reaction. And this is attributed to high ammonia. They can be on vasopressor support. That also has a binding on the pupillary signs. But here was a case where there was acute onset low BIS and unequal pupil and sluggish reaction. So it was not very clear. In the literature, there are certain cases where they have mentioned that absence of pupillary response is associated with poor prognosis, but neurological outcome has been favorable in some of the situations after transplant. However, when they have brain herniation, obviously they are associated with strongly with mortality and severe neurological outcomes, irrespective whether they had a transplant or not. So we were not sure whether what we did was the right, but in the end, when she recovered, of course, it was a right decision. Coming to the second case, this is a small baby, 18 months old male child, AB positive cryptogenic ALF with a triad of encephalopathy, coagulopathy, jaundice, irritable child, intubated and admission. We did a brain scan and there was a lot of edema. There was no midline shift, no herniation, but the edema was more than usual. He was already started on anti-edema measures. We took a neurologist opinion and we didn't know whether we should be declining a life-saving procedure in this child. And the neurologist felt that in kids, we have neuroplasticity and they develop new connections, they have rehabilitation, and they do recover. So a procedure like liver transplant, which would be a life-saving procedure, should you deny this procedure? So we informed the family, and the mother was willing to donate her left lateral segment. Transplant was performed. Post-transplant, child was hemodynamically stable, had a stable graft function. However, the child did not wake up. He had a tracheostomy, spontaneous breathing, feeding was established, immunosuppression was established, and he was in hospital for almost 3 months. We didn't know what to do. And every day we were hoping that there would be some response. In 3 months' time, towards the end, he landed up with chest sepsis, CMV infection, and we lost the child. Here is a case where the family was very hopeful. We were also hopeful, though we knew that the edema was more than usual. However, we had an ethical dilemma whether to deny a life-saving procedure. We lost the child, family understood what we did. We did what we could have done, but we really don't know that neuroplasticity was of a help We were hooking on to it. It did not work out. Coming to the next scenario, ALF with pregnancy. The first case is a 28 years old female, HEV-related ALF, 8 months pregnancy, fulfilling criteria for emergency transplant. We worked her up for an emergency transplant, and at the time of transplant, there was fetal heart rate. That is just prior to the transplant, while we were working up. And the decision whether we should deliver the child or save the mother and do the transplant first. There was a lot of dilemma with the obstetricians. They were reluctant to go ahead. And before wheeling, go ahead in the sense to do a delivery prior to transplant. So the decision was we do the transplant and they deliver simultaneously after the procedure. However, before wheeling to the theater, there was an intrauterine fetal death. There was no heart rate. And we performed the liver transplant. Again, there was a debate whether to do the delivery and evacuate the dead fetus. The questions were when and how to evacuate, whether this intrauterine fetal death would pose a risk of infection, a bleed, or a DIC, and a lot of dilemma that we could retain the dead fetus and we could do elective evacuation, maybe a medical induction. And all this led to nothing. We did not perform any procedure and the dead fetus was still there. And the obstetricians were in dilemma. A lot of discussion happened. Fear of PPH was there. Post-liver transplant, the patient woke up. There was good graft function. Extubation was done on the POD1 late in the evening. And we were still debating with high immunosuppression and the fear of infection, DIC, bleeding, when to evacuate, when to do the induction was still in our minds. On the second post-op day, while positioning, she actually had a spontaneous expulsion. There was no significant event following that. There was no sepsis, no DIC, no excessive bleed. So looking at the literature, whether a dead fetus, what could have happened? I did not find any literature where a patient had a transplant or was exposed to immunosuppression and there was a dead fetus. But there were few things in the literature about how to manage a dead fetus, and the fear of blood loss infection has been stated. And how to manage, we can have a medical induction, surgical, that is cesarean, or expectant, which is a spontaneous expulsion, which is what happened in our case. Now coming to the last case, this is a 39-year-old female, cryptogenic ALF. She was almost term pregnant with twin pregnancy, and she was shifted late to our hospital, landed up in ICU, grade 3 encephalopathy, high bilirubin, high INR. She was on inotropic support for hypotension. She had renal dysfunction, and she was started on CRRT. She fulfilled the criteria for emergency transplant, but she was quite sick. We explained to the family about the risk of doing the transplant and vis-a-vis leaving her alone, and that this was the only chance, if at all, they took the risk. There were 3 willing donors in the family. However, we listed this patient in the DDLT list as a super urgent case, and there were fetal heart rate at the time when she presented to us. Now, again, the question was whether you should be delivering the fetus before transplant. Here was a sick patient on inotropic support, CRRT. Reluctance was both from our side and as well as from the obstetrician side. We were worried about the hemodynamic instability, coagulopathy, landing up with PPH, sick mother, and we had to save the mother, and delivery would have been planned at the time of transplant. So a rapid workup was done, and actually she received a organ in emergency and she had a DDLT. While shifting, we realized there was no heart rate, and we were again having 2 intrauterine fetal death. And since there was full-term gravid uterus, explant was quite difficult. And we got the obstetrician to do a cesarean. and deliver the stillborn babies. There was uterine atony, PPH, transfusions were given, we waited. And then once the bleeding was under control, explant was performed, reperfusion was done, arterial and bile duct anastomosis was done. After that, patient had hypotension, hypoxia, bradycardia, high airway pressures, and sudden pulmonary edema. Labile hemodynamics, refractory hypoxia and hypotension, shifted to the ICU in a very sick state, informed the family, and she succumbed in 24 hours. Here the intent was to save the mother and the babies, but we landed up with dual tragedy. I really don't know what could have been done differently. There was an aim to save the mother. We don't know whether, I really don't know whether the patient was too sick to transplant. ALF, renal dysfunction, hypotension. I'm sure many of us are faced with this situation. And a wiser thing would be to inform the family and go ahead. Should you try to save the babies? Whether the mother was too sick to deliver before the transplant. And we always try to save the mother before the babies. So the lessons, I don't know whether I learned any lesson or the dilemma was just even more. Should we declare too sick to transplant? Should we attempt delivery before liver transplant because the babies were term viable and they had a heart rate at the time of presentation? There was a maternal and neonatal mortality meet which I had to attend, and I was faced with the same questions. And they were very harsh. And I had to answer these questions: why live fetus was not delivered before transplant? Why did we go ahead with transplant? And I don't know whether we have the right answers. So I can only reflect in these two scenarios that ALF and neurological status, there is still lack of clarity. Neuroplasticity in young individual, should you deny the only chance of cure or a chance to live in a patient who has neurological deterioration, not really midline shift or a herniation, where we would not have proceeded obviously. And especially when you have a living donor posing a risk to the donor versus wasting a diseased organ, I really don't know whether we should proceed in such a situation. In the other scenario also, when you have a viable fetus, sick mother, what is the sequence to follow? Save the mother, what about the fetus? These above experiences, has they made me wiser? Probably yes, because it adds to my experience, but I don't know whether I'm faced with a similar situation, I will be wise enough or not. We always talk about evidence-based medicine, and the highest level of evidence is RCT. I don't think we can have RCT for all situations. And levels of evidence, grades of recommendation versus expert opinion, I think in today's date, it has a similar strength. And I strongly believe that we should be sharing failures. It teaches you bigger lessons, maybe. And I'm open to discussion. I would like to learn from others how they would have managed such a situation. Thank you.
Thank you, Vibha, for sharing your experiences. Before I go into asking you questions or discussing some of the thoughts of mine, I would request Dr. Nandi sir to actually start off the conversation. Sir.
Speak louder, Sumana.
Yes,
I think
it's wonderful that you were so honest and put your dilemmas clearly, and a very good start to a meeting. Congratulations.
Thank you, sir.
Okay. Yeah, like sir said, I think you have shared your thoughts and your retrospection, feeling of whether we did the right thing. I think many of us actually have these thoughts after some cases that we have experienced. Some of them may be good, some of them may be bad. But if you look at the futility, the thing of futility comes in transplant, it is always about um, survival. Mostly it's not about like a physiological futility, or will they have a good quality of life. It is more about whether this person, after doing so much, will survive, is the question most of the time it arises, unlike in many other cases, like in medical cases, where it can be like I said, whether we are going to give him back the regular physiology or, quality of life. In your first case, that's the first child, isn't it? Is a child who had some BIS, which was almost zero, you said?
And she was a third-year-old medical student.
Medical student. I think, see, BIS cannot be taken on its own to say how much brain damage is there, or how much depth of, especially when the patient is in on anesthesia. And the other thing is that this cannot be taken independently of other clinical assessments, or you have, I don't know when did you do this? Maybe a transcranial Doppler introp can also be done. All these could have seen, and maybe you really realize, because of the fluid shift that's keep happening during the anesthesia, there's a possibility that and the anesthetic drugs, there is a possibility that they can have unequal pupils. So maybe there
We
was no
did
dilemma
have
at
this
all.
discussion, yeah,
Mm.
that what was disturbing was the inequality of the pupil. And BIS zero, I agree that we can have in ALF. People have come back after a BIS of zero. But here was something which wasn't there to begin with, and she had an edema, and we didn't know whether it progressed while we were doing the explant, whether she had a irreversible. That is the dilemma which we face actually.
Okay. As do we have any other questions on this first case? So I thought we'll go by each case. So do we have any questions from the audience with respect to the first case? Gomati, I think. Gomati, you can go ahead.
Hi. Yeah, hi. Hi, Sumana. Hi, Vibha.
Hi,
And
Hi.
hi, good evening to all of you.
Start
Vibha,
your
very
video.
interesting. Very interesting,
Start your
Vibha.
video.
No,
If you
I will
can.
go just with audio.
Okay, that's okay.
So, Vibha, I mean, I think in the overall context of things, you had a 50% good outcome in both the situations you mentioned. I think when we're
Yeah.
dealing with such sick patients, be it ALF in pregnancy or neurological status, a 50% is something you would still say, then in which case I'm going to give it probably the same kind of shot when I get a situation the next time. I wouldn't think differently, because in ALF and such sick patients, 50% is worth the try. That's how I would look at both your cases. And also because not much of what you had in hand could predict whether it was going to go this way or that way. So I would say the call was right. Now, in the second, Sumana, I'm just going to give my thoughts on all of them, if that's okay, on all the
Go
cases.
ahead.
So on the lady, the 39-year-old lady, had you, I mean, if you had a live donor, would you have done things differently?
No, actually, we had worked up her sister. She came in the evening, night, 8 o'clock. Overnight, we worked up her sister, and we were due for an emergency committee early morning when she got a liver offer, you know. And they had a family which was like everyone wanted to donate. Even with 50% risk, we gave them a 50% risk. They were willing to take that risk.
The
So,
reason I asked that was, then this question that you faced in the committee, asking whether you would have gone ahead and delivered. Because if you had a liver right away, be it a live donor or a deceased donor, would you now consider going ahead with delivering the kids? Because the worry that you had, anyway, you had to face it when you had to take out those dead fetuses. So
yeah.
the same would have applied had you delivered the babies when they were alive. So this is a learning point moving forward. Would that be something you would do?
So I'll tell you, Gomati, that we didn't have time. Actually, sometimes we could have done, but it wasn't night. Patient comes in, and in fact, the obstetrician received the call because she was term pregnant, almost term pregnant. And then they're so reluctant with the INR. She had a PT of more than 120. She was on inodrop, she was on CRRT. Now, whether you want to take the patient to, so they told you take the patient to OT, do the transplant, we will deliver. But during that period, we lost it.
Yeah.
Can I say something here?
Yeah, but this is a question which I really don't know. Because this is what we faced in the maternal mortality meet. There were very strong questions. Why didn't you save the babies?
They were full-term babies, no? They are not
They
like...
were 34 weeks, yeah.
34 weeks.
Viable, yeah.
Viable,
Beyond
mature.
32.
Yeah. I mean, it's not like 28 weeks where you know that, it's yes or no. I like maybe small, premature, all those things. But here
No, that is different scenario altogether.
I also would say, why didn't we do everything that we could to deliver these children out?
Yeah, but when we tried to do, there was no heart rate. We transplanted her within 24 hours.
Before going, because see, this patient was very sick, right? She was already on CRRT, on inotropes. I don't know how much exactly, but with correction of coagulopathy, taking if the family was so much keen and they were okay for a 50% mortality, anyway you are going to wait for transplant, whether it's LDLT or DDLT. There is at least a minimum of 6 to 8 hours or 12 hours before you can take up for surgery, right? Even if there was a living donor and all these things took a while. I think the for whatever reason the gynecologists or the obstetricians should have taken with an extra risk.
Can I ask something?
At least we could have saved the children.
Can I ask something here along these lines? Yeah, when we are talking about delivering the babies in such cases, I know that Vibha ma'am has mentioned all the techniques. Which would be the best in your opinion? Isn't it better to go in ready for a transplant and then do like a cesarean section and then turn your attention to the liver? Because I think things will be a lot more under control. Even if you do induction of labor, it will typically take so many hours together, right? What is the guarantee that either the fetuses will get delivered on time or the patient will remain stable till then? What's your take on that, Vibha ma'am? And that's one thing. And second thing I wanted to ask is, Gomati ma'am is still there, yeah. So this is, I think, a common question now. So 50% chance, yes, you'll take. So up to what percent do you take, and beyond what percent do you say that it's futile? I mean, what's the tentative number in your mind? Because a lot of these things, like recently, we also had a ALF case with some sepsis. So in those kind of cases, when things are likely to be stormy in the post-operative period, rat all poisonings where there's multi-organ involvement and all of these things will be, I mean, even to say 50% is difficult, right? So what's your tentative number in your mind? I know you can't give any number there, but then what's your take on this?
Rat all poisoning with multi-organ dysfunction.
It's ruled out, but like where do you draw the line?
That's why I think in the whole world, the acceptable thing is 50%. Now, my question is, how do we decide it is 50%?
50%, exactly.
So these are questions which cannot be answered, I feel,
So to answer Shruti's question and to counter what Sumana just stated, see, the patient who is sick and has a viable fetus, we would like to save the babies, but then between the babies and the mother, you also want to save the mother. If you try to induce labor, you can't do a cesarean. The option is only inducing a labor and delivering the babies. Do you want to start a drug and induce and do a bedside delivery in a hemodynamically unstable patient who can bleed to death.
No, I think, I mean, in my opinion, Vibha, you can't wait for a normal delivery in her, because the cause of death of these the babies, I mean,
No, so you would have
the
taken
death
that.
is because of placental bleed. That causes
Yeah,
because
so
in blood
you mean
supply
to
to
say,
the
I want
fetus.
to understand, do you want to take her up for cesarean, you mean to say?
Yes, yes. If you are so aggressive, you should have done that.
Then you could have made
Yeah,
an
no,
There are
antibiotic as
I
different
well.
would
factors
be
that you can
quite
give. You can
reluctant
give.
to do a cesarean in such a patient where we are working up for transplant, because we did land up with a twin pregnancy. I'm talking about this patient. More
That's right.
chances of
More,
atony and
more.
PPH.
That's why more twin
GT.
pregnancy.
No. So more chances of uterine atony and PPH,
ऐकते का मग एक
irrespective
वेबिनार आहे
of the situation.
ट्रान्सप्लांट वाल्यांचा इंडियन.
Oh,
It's okay, we've muted the person.
so I think, Vibha, in such scenarios, the question arises that the patient will bleed of PPH. So if you have a good aggressive obstetrician, you can take a consent for hysterectomy and still go ahead with cesarean section.
Yeah, that is a possibility, yes.
So because see, ultimately here, if the more time you given, like say if you look at the other one, 28 weeks, there also little bit extra time, we know that there'll be IUCD. So if there is a viable fetus, the first thing that you should, if you can actually save them and you have a good neonatal facility and all that, the first thing is you should take the baby out.
And can you make do the explant and make anapatic at the same time? Is there any literature on that, like for you to buy?
That's a great question, because you
You're
can
going
actually explant and do a shunt and wait for the organ if you have a living
make
donor
anapatic.
or even a cadaver. People have done that.
Any thoughts on that, Vibha ma'am, Gomati ma'am, the seniors?
What about the prothrombin time? Considering it was extremely deranged, wouldn't that increase the risk that a cesarean section poses?
No, but I think Sumana's point that we could do a hysterectomy. Here we're talking about the lives of both the babies, and if you can save, that would have really added to trying to save the mother also. And hysterectomy, I'm sure the family would have been okay with that if bleeding was our concern. That was the only concern, isn't it?
Probably.
I
And
think even just in tying off for the internal iliacs, embolization, so many options. So we could have forgotten the uterus and taken care of
Because
both
it
the
was almost
kids
34
and the mother. Yeah.
34 weeks is like.
The other thing, Shruti, you mentioned about is 50%, where do we draw the line? So there are two ways to look at it. In this situation, now we are retrospectively considering whether we did is the right thing or not. And if you look at retrospectively, if you have a 50% outcome, you would still do the same thing in the future. That's what I'm trying to say.
Yeah.
You would not think twice because you've achieved the 50% there. Now, in a particular situation, when you're faced, how do we put down the numbers? It's a very tough call, but there are definite organs. If those organs are involved, then the outcome is poor. So I think we need to go by not just the overall picture, but looking at, if it's ACLF, which are the organs we know, if it's ALF, we know. So I think we'll have to go by the lung is really bad, that, they're not going to do well. So yeah, I think it's not a number, but it's understanding the clinical scenario, I would say.
Dr. Kush has his hand raised.
Yes, ma'am. I had a question to Dr. Vibha. Ma'am, thank you for sharing your wonderful experience and the challenging cases that you faced in clinical practice. Ma'am, up to what extent did you evaluate the recipients in both the ANC cases?
We
When
did
the recipient
everything
was so
for a
sick?
surgical fitness.
Because in these cases, radiology is always a question because both were ANC patients with viable
So
fetuses.
they are ALFs, only baseline ultrasound. We don't need much.
Only baseline ultrasound based. Okay.
Yeah. So basically in ALF, you do a bedside ultrasound. We don't need imaging like a CT or anything because they are normal livers. And ultrasound would suffice about the vascular anatomy also.
Vibha, in your second case, if there are no questions, can I ask one?
Right. Thank you.
In your second case, the child, isn't it, who had very severe cerebral edema?
Cerebral edema, the child who did not wake up.
Yeah. So at what level do you, I mean, anybody can answer this. At what stage of cerebral edema do you say that, no, we are not going to do this case?
So I'll tell you why I mentioned this case, that he did have squashing of his cerebral gyri and sulci. Normally, we would have not proceeded, you know.
Mm.
So here was a kid where there was a lot of discussion. First child, 18 months old baby, young parents, and you tell them we can't go ahead. Then we had a discussion with the pediatric neurologist, and she told there is something known as neuroplasticity. To tell you very frankly, this is about 8 years back, and I read what it is. And she told there are rehabs for such kids. And if you are going to go ahead with a life-saving procedure, explain to the family that it can be either ways, but if they are willing, we go ahead. So we did have this fear that the child may not wake up. And this is what happened. So, in fact, it was something again like a 50-50. We
No,
didn't know.
there was no 50-50 here, according to me.
Sometimes you have brain edema which recovers, you know.
No, but if you're saying the squashing of the
Yeah, so the thing is, it was not, there was no midline shift. It's just that the making of gyri sulci was more than what you normally see in a ALF situation.
So, no, ma'am, but in this case, if we have to think about the double equipoise situation, if it's a left lateral segment, living donor, low risk, so is it, what's your thought on that now?
So
Is
I
there,
would say that explaining to the family is also important. You say that let the child be, and it is 100% off. Whereas you are giving a small chance. So it is something which in a living donor, and as you mentioned that a small part of the liver, low risk surgery, are we the ones who take a decision not to offer that? So it can be argued either ways. I really don't know whether we have a clear-cut answer. Even in the gravid 39 years old female, I don't know what we did, whether there was anything which we could have done differently. To tell you very frankly, even the twin delivery, I don't know whether we get faced with the same situation, whether we are wiser with this.
No, I mean, to make it simpler, in case of your ALF with the twin pregnancy, the thought process, I mean, to make it very simple for everybody, you have to save lives, right?
Yeah.
You cannot say, immediately what you can do is to save one life, because the other one needs another person to give liver, right? This is only cesarean section. You have so many factors that you can give and still go ahead and do whatever you can to the extent of actually getting the uterus out. But you can still save these babies. So the next thing comes like, okay, now that we have saved these children, the other life that needs to be saved, which also needs another life to give that life, no? It's like you need one more person to give the liver for her to survive. It is not on its own, the children will survive. For the girl, for the lady to survive, you need a liver from outside. So the decision is like immediately what we can do. Immediately, the first thing that you could do is actually save those children. And many a times you deliver. In this case that was hepatitis E, isn't it? Sometimes when there is cryptogenic, we don't know whether it's the pregnancy itself causing it.
Yeah, so that's why you mentioned.
So that's why
this
they say the
particular
first thing you
case,
should do is get the baby out.
So in this particular case, it was not that delivery would have made any difference to the mother. But yes, they were viable fetus. They were viable fetus. And
I think I think you should have, I don't know, I mean, it's my fault. If I was there, I think we would have forced the gynecologist.
yeah, because we go by this, that you have to save the mother first. Yeah, but when you have a viable fetus, it's not very clear. I really don't know.
We have to save the person who can be saved first.
Yeah.
Not the mother or the child.
Triage.
Ma'am, I have one more question. Ma'am,
Yeah.
what is your experience with bridging therapies in such situations when you are taking some time to procure the organ,
Bridging in the sense?
Oh, plasma
like
exchange.
liver dialysis or
Already the
yeah.
patient was
She
on
was
CRRT.
on CRRT. She was on CRRT for two reasons. She had renal dysfunction. She came with a creat of 3 and she had raised ammonia. She was in a grade 3 plus encephalopathy. So we did initiate CRRT.
I think he means Mars, or like, are you asking about?
Mars and all we don't do. I
Okay.
don't know. People can express plasmapheresis, CRRT. These are the two things which people do. But in ALF situation, if you have a donor, you can actually work up and have a committee done within less than 12 hours. And yes, but people can express their own opinions.
Dr. Manpreet had something to ask, and Dr. Gomati after that.
So I wanted to ask, we're doing this discussion about mother and child and priorities, but how much was the time between the mother coming in and the IUD happening? Like,
Yeah,
was
so
there
that's what
enough time to
I
do
was
a
actually
delivery?
trying to say, that mother came at 8 p.m. today. Tomorrow, 8 p.m., the surgery was over. So it was not, but yes, I'm sure all of us in transplant, we do the same, and especially if you have a willing donor. Sometimes even in less than that time. But this is what was the timeline. She came in the night, there was a heart rate. Next day, when we had a committee and when we were wheeling her for theater, before that itself, in fact, by evening, when the obstetrician had a review, they could not find the heart rate.
So, like, maybe less than a couple of hours. It was just a couple of hours.
Not couple of hours. It was
24 hours.
then it was about 10 hours. Yeah.
And my so, Dr.
24
Sumana,
hours.
if this is the timeline, and maybe there was not even enough time to do a cesarean on the
See,
what?
I think what Sumana says,
Cesarean,
it's
there's no question of
it-
time.
huh?
For cesarean section, how much time does it take?
But what if the obstetrician is not willing, like ma'am said?
That's
So
that is the
Manpreet,
thing. That the question is.
so I think it boils down to what the priorities were. I mean, it's not I don't think about time. It's the overall thought planning, which there were multiple factors, but it's just the question of whether that thought was there at that point, that it's okay to even go to the point of a hysterectomy. And of the 3 lives, how many can we save? I mean,
Yeah, correct.
yeah, I think that's it. The rest of it, depending on that thought process, would have fallen in place, whichever way we wanted to go, actually.
I think I'm open to learn from what it gives me a thought to think about. When
Yeah,
you are
Vibha, it's extremely difficult. I mean, retrospectively, we are analyzing it, but we're talking about a 24-hour timeline with lots of ifs and buts there. So it's just probably next time when we come across a situation, we probably will think about this also. The only other point I wanted to add was in the child, like you said, I mean, just something that out of observation. In children, we don't really see a midline shift or a pupillary, because the
they
fontanelles
don't
are
have
open.
space.
18 months. Yeah, 18 months. So edema is the thing, and that's where there's a trouble. So it's very difficult. Of course, I'm not sure the optic nerve diameter and all of that, whether 8 years ago, whether they were doing it as much as they're doing now. And the other thing would be to really do a brain imaging with an angio to see if there is vascular cutoff, if you really think. But your case, I remember you said on table is when you started showing the dip in the neurological signs, isn't it?
That was the other case.
Yeah, the child, 18-month-old child.
No, the unequal pupil was the medical student.
Oh, on the other child. Okay.
Yeah, she
Got it.
recovered. She actually
Super.
had a
Okay.
very, yeah, she recovered.
Yeah.
This
Okay.
child had pupillary things and all were okay. It was the edema which was disproportionate.
Yeah.
But generally, I think in any transplants and unit, if there is more than just a very mild cerebral edema, then we don't take those cases, isn't it?
Not always. It's always a dilemma.
I don't think mild edema is the only thing which you accept. We've accepted more than mild.
Because
And
I
of course,
have when I was in Medanta, I know that there was a 16 or 17-year-old boy. He never woke up with I think that it was not even like it was not a very severe edema, but probably a mild cerebral edema, but he never woke up after transplant. So we don't know, like you're saying that, what kind of fluid shifts happen during surgery, what causes the worsening of cerebral edema. So those
if
things
I have to
we
discuss
don't
one
we
more
can't say
case.
this is the case that it will happen, and in this case it may not happen. So that's a risk that you're taking. But generally, I think everybody tries to make a rule for themselves, saying that okay, there's a little bit moderate to severe cerebral edema. Then should we really take this patient to OT? The question arises.
So I have one, not related to the case, but just a separate general question of pathophysiology. When we consider children, the blood-brain barrier would not be very well developed. So is that why you say that, does that change the decision making and the ammonia levels which are used, or the bilirubin levels? Are they different for a small child like the one ma'am discussed it?
In terms of?
Because the blood-brain barrier would not be developed, right? Like kernicterus also happens in neonates. So does that change the decision making in children regarding transplant?
No, I don't. I mean, I don't think when it comes to edema, I don't think probably you would give a little more chance to children compared to adults. But like say, if an adult is there with mild edema also, then we'll start thinking, should we really go ahead? But if it is a child, probably you still go ahead at this stage, and then you may win it or you may lose, and then you have to take the consequences.
No, like what Manpreet, you are asking about blood-brain barrier and kernicterus. Here's a different situation. You have a
What
triad.
about, that's
You
what I
have
said.
a ALF situation. So that is, it's not the level of bilirubin alone. You have other factors which are also playing a role. And I will tell you, in this case, I totally agree that it is a plus minus situation. But here is a kid where we as surgeons felt it was a little advanced. But here is a neurologist who says, yes, let's discuss with the family. And this outcome was always discussed. And we kind of knew that we may have this outcome which we really had in the end. But it wasn't clear. It wasn't clear to say that, okay, we won't go ahead when you have a family and a living donor in hand. But yes, it is questionable to go ahead.
Shruti, are we closing? Is it time?
So
I
just
think
before,
Yes. Okay. Hi, I'm Sharvari.
Hi,
Hello.
Shraddha.
Hi.
Hi, madam. So really enjoyed, madam, your cases and the discussion also. I'm really too junior to give comments on the
No,
decisions in
genius, you don't
transplant.
have to tell.
As far as transplant is considered, about the decisions taken and the outcomes. But logically, what I feel is your intention was good, as the theme is futility versus hope. If there is, the intention is hope, and we are taking the chance of at least 50% success, then absolutely justified in taking up the first two patients for transplant. I just wanted to make a comment on that. I agree with Sumana madam about the deliveries in the last case. And I just a few months back, I overheard when with my gynec friend that she was going for a meeting for the guidelines for peri-mortem deliveries. So I was also wondering what is this guidelines for peri-mortem deliveries, and then we discussed what is this, and then she said it is about something when there is a road traffic accident and something like that, and the mother is dying, and then what should be done. So I think there are guidelines by now, or maybe the recommendations or something like that, and they are working on it. So what is to be done in such situations when the mother is dying and we have to save the children? So I think it is there, and that
Yeah,
should
but I
be.
would disagree on this, that this was not a mother who was really dying. She was on inotrope, CRRT, but it was not a situation where she was far too gone for doing a transplant. It was the combination of pregnancy and ALF which
That was
ultimately
more culprit.
culminated in
Okay,
losing both actually.
I think.
But
But
I won't say that she was far too gone as a surgical candidate. She was,
Vibha,
Okay.
I
she
differ
was,
in this. The
mhm.
children had 100% survival,
Yeah,
but,
yeah,
but
that
the
was,
mother had only 50% survival.
yeah, that
So
is
you,
true. That
you
is
could have
true.
still saved the children.
Mm.
Shravanti?
Ma'am, there are a couple of questions in the chat.
Yeah, please.
Dr. Meenakshi is asking whether the family can take a decision about whether the mother or the babies can be given priority.
Whether the family can decide, yeah.
I think they can decide, but the clinician also has to agree. See, you can't force a clinician to do a procedure which he or she is reluctant to do. But yes, you give the options. You can give the options. Why not? Nowadays, we take family decision, no? In making any decision about treatment, every treatment plan is discussed with the family.
So what if the family says either the mother or the child is the priority while the clinician differs? Would you stick to your plan or would you go with the family's plan?
See, we can't go against their wishes. There is a big consent which you take, no? You have to tell them what is right and they have to agree with it. You can't obviously go against their wishes.
Well,
So,
here comes another ethical dilemma, right? If the family prioritize the life of the child, or the way it used to be in the past,
yeah,
probably.
yeah.
So
I'm
where
thinking
do
of the
we?
movie now. Sorry.
It is like we are going. So it is not clear. See,
Yeah,
I agree totally with Sumana's thought process that here is the live baby. But I know that when you are faced with that situation, the timelines, how
Exactly.
do you go ahead? The logistics,
See, I think like
even
Gomati said,
logistics. Yeah,
so
with the
many things
willing
are going on
clinician.
simultaneously. The
Yeah.
transplant surgeon is more busy with thinking about trying to do a transplant for this lady. If at all, if the obstetricians were more aggressive, probably they would have taken this forward and done what they had to do, which
Yeah,
they didn't do.
I would say that not every obstetrician is very aggressive in managing a fetus in a
Not
ALF situation.
most of them.
Yeah, yeah.
Yeah,
But
that is one challenge.
I'm actually thinking maybe my obstetricians are poor. I don't
No,
know.
no.
I
But
think time gives most of the answers in these kind of situations, right? Where things go along a certain direction while things are being prepped. Anyways, there's one more comment there. Delivering babies makes significant changes in hemodynamics. Saving babies and significant change in dynamics gives a chance for liver to recover, and transplant, even if needed, may be better with success rates. For obstetrician to take this call rather than transplant surgeons.
agree. So
But
they have to
sometimes
take
the
the call.
obstetrician would not be willing. They might be also scared because it's a new situation they haven't faced previously. Probably what happened in this.
Yeah, maybe.
Yeah, I mean, not everyone has that massive experience. In fact, we also don't have so many pregnancy and ALFs, no? We do have a handful of which you will remember always.
So before we close, in retrospect, uh, what would you have done differently, Dr.
So
Vibha?
if you ask me in all the four cases, I do have my thoughts. It's very personal, but in the young child, probably we shouldn't have gone ahead. Even if the family was willing, We should have told. And after the baby died, within 6 months, the mother called me asking, when can I become pregnant? Because, when a small baby is there, they feel bad, but they want to have a family. The other medical student, I think it was very a good decision to go ahead because there was a lot of discussion. We actually stopped and we had a discussion intra-op with the family, with the neurologist, this, that, and all. It was a good decision to go ahead, and obviously she recovered. The third scenario, the 8 months pregnant, we were again discussing about their delivery thing. Pre-transplant was not considered. The patient was very stable. ALF, but a stable ALF. So we decided to do the transplant and delivery at the same time. Unfortunately, we lost the child during that period. And post-op, we were worried about infection, DIC, this, that, and all. Did not have anything of that sort. So I think a spontaneous expulsion is mentioned in the literature. Of course, additional transplant is not mentioned. 39-year-old female with twin pregnancy, I think she was sick, but I don't know what I would have done differently. But I agree that a viable fetus to save, there is nothing to counter that. I cannot argue that. So maybe we should have thought about saving the babies.
Right, Dr. Sumana and Dr. Shruti, any difference in opinion?
I don't know. It's it's very hard to be put into those situations firstly, and it's hard to make any decisions in them. Something, at least at this stage of my life, I would want to involve more people into decision making in such difficult situations, because you'll have to live with the burden of the decision as well. Other than that, yeah, thank you very much, Vibha ma'am, for sharing such very stimulating cases. And it's bittersweet. One positive outcome, one negative outcome, just shows the nature of the disease that we are dealing. And that there will be more questions than answers in this field even in the future. Sumana ma'am and anyone else want to make any parting comments and close, please?
I think, like you said, I think many people, more people should be involved in decision making, so that it will be a combined decision. Probably you'll get a different opinion from different people. Maybe somebody who's not in transplant actually would give you a better advice at that time. And when it comes to decision makings, like children with that severe or moderate amount of cerebral edema, you may be sounding a little, not so helpful for the family, but in the end you will feel that, okay, what you had to do, you had to do, because we are not here to save everybody. And most of the times, especially the doctors, that playing God comes to us. So that's why more and more multidisciplinary meetings and thought processes from different people, from different experiences comes into play, rather than taking only one man's or one woman decision. So that's where you will all come to a decision, and then you will not get back and start thinking and why we did this, why we didn't do that. That thing will be less, I would say, not like to the extent when one person takes a decision.
I think we always have discussions within our team, but I agree that you should have maybe more clinicians who are not directly doing the transplant, giving their thought process. Because this is what happened when you are in a sign hospital and their opposite people is nowhere a transplant surgeon, nowhere a obstetrician, and having some hard questions posing, and they don't just agree with what you say, and sometimes you feel whether you are really justified in what you did. So their aim is neonatal mortality rate, maternal mortality rate.
That's what, no? As a surgeon, you think about only a particular thing.
Yeah.
Then maternal mortality or neonatal mortality or whatever that their mind keeps thinking only about that.
Yeah.
So that's why I think if you see in the Western world, these things are made easier by many people involved, including a social worker, psychosocial worker, psychosocial worker who even comes and question whether the mother's decision in saving the child is only purely emotional and there is nothing else involved. They even try to assess that. Because see, sometimes when we are emotional, we don't even think. No? There is no cognitive thinking. It's just emotions are playing. So that is when, all these multidisciplinary involvement sort of helps.
So is there a role for
I
a
have to
transplant
say,
board, like a tumor board?
There
see,
is.
you do have a
Yeah,
MDT,
I
but
think
most of the ALF situations you're not able to do I'm sure, because it's an emergency situation. We take decisions amongst the team. But when you have an elective situation, you have more people giving opinions.
It
see
may not
one
be
thing.
formal boardroom discussions, but then many a times you tend to consult your hepatologist or your neurologist on the phone and just,
Yeah, of
take their
course.
opinions. That's the way it is here. Yeah. Hmm.
See, and the other issue, sorry, before we close, I think in Indian scenario, it is not about the if you look at the finances also, it is a self-paying healthcare. The patients are paying for themselves, not like you have an insurance coverage or something else taking care of it. So this scenario becomes a little different when you start talking about futility. So the futility of the do everything, I will take care of it, even if it is 20%, 30%. I mean, we have seen patients coming and telling us that I am donating and I have the money, so do it. So that is a question mark where we should draw a line there.
I think that's clinical futility and financial futility,
Yeah.
what we should differentiate in Indian scenario.
Indian scenario, it's more difficult actually compared
Yes.
to the Western world.
Yes.
Yeah, because here, I mean, it's not two different things. Eventually, it comes together, especially
Yeah.
with I mean, sometimes people are coming to the private not because they're affording, but because they don't have another option. And then till what level can you
Mm.
try their finances is also a question.
Yeah. So that is the question you have to keep thinking, doing. It's a part of being a doctor, I feel.
Okay, thank you everyone for joining in. This was a very interesting discussion. Ethics is always an interesting topic, and no better, field to discuss on ethics than liver transplantation, and even in liver transplantation, acute liver failure. Thank you very much, Vibha ma'am and Sumana ma'am, for making this so interesting. We'll announce our next lecture again in a couple of weeks. Hopefully, we'll have a lecture this time on the third week of this month. So stay tuned for updates. Okay, bye-bye, and
Bye bye. Good
let's get
night.
back to our IPL now.